This is circulatory physiology in 4 parts. Part 3, blue blood. In this section, we'll cover venous circulation and its structure and function and regulation. And as blood moves to the right ventricle, talk a little bit about how to evaluate RV, especially in situations for failure. And we'll look at the pulmonary circulation as well. So first off, a couple things about this venous circulation that contrasts with the arterial is this is a very high capacitance system. About 70% of your blood lives in the venous system. And it has a reservoir that we sometimes call venous capacitance, which I guess you could think about as a spare tank wrapped with vascular smooth muscles and alpha receptors that can be kind of recruited to be squeezed, so more blood makes it back into your central circulation, or dilated where you could park blood there according to the body's needs. So the other thing is that whatever blood is pumped out to the heart from the left side has to be returned to the left side to make it through the pulmonary circulation. So venous return is equal to cardiac output in all situations. Now, in terms of venous return, a few factors impact that, which we'll talk about. They are the mean circulatory filling pressure, the resistance to venous return, which doesn't really come up too often clinically, and then right atrial pressure, which is basically CVP, which has already gained a bit of discussion in some of the prior sections. And then it also kind of is dynamically regulated as described, especially in terms of recruitment of some of the capacitance, venous capacitance where blood is stored. And it's a very low pressure system as well. Okay, so a couple terms here that come up. And one is the stressed and unstressed volumes. And so the definition of an unstressed volume, or actually let's just forget the definition, but let's just picture a situation where you're slowly adding blood into a body and then it doesn't really, and you're also measuring pressure, say venous pressure at the same time. And so for a while you can add blood to that body and it will not generate an increase in pressure. And so when you start adding blood, and when you start adding the volume at which you start to see pressure increase, that defines what your unstressed and stressed volume is. So it can be a very low volume as depicted here, or it could be a moderate or even a high volume. And that's just how much blood the body can handle before it starts generating pressure. And as you can probably guess, that if you say put somebody on an alpha agonist drip, they're going to have a lot of their veins and their venous system is going to be constricted, and it's going to be a very low amount of filling that can occur before you start experiencing an increase in pressure. And if you give somebody, say, a venodilator like nitroglycerin, well, then they can handle a whole lot more blood before you start to see an increase in pressure. And so, and this, assuming that the circulatory system is at standstill and there's like no cardiac output, the other thing that you would call the kind of the border between the stressed and the unstressed volume is the mean circulatory filling pressure. And that's basically the pressure that is experienced or that's generated by the volume in the body when the heart is at standstill. So if you can imagine, right now, if I had a cardiac arrest, you could measure my pressure in my system. If I receive several liters of intravenous venous fluid or blood, and then you stop my heart, it would be kind of a higher level, higher mix, mean circulatory filling pressure. And that's actually the pressure that is in your system that is exerted against the right atrial pressure that forms the pressure gradient that gives rise to venous return to the heart, and hence the cardiac output that your body will experience. So kind of a more elaborate looking curve would be this one right here, where again, these are pressures, not volumes, but so again, when you have, this is like the relationship between right atrial pressure and cardiac output. So when the heart stops, you would measure different pressures in different situations, and this is called the mean circulatory filling pressure. This probably reflects somebody who's relatively hypovolemic. This is someone who's pretty well tanked up. And the relationship here is that when the right atrial, at a given mean circulatory filling pressure, the lower the right atrial pressure, the more venous return you're going to get, and hence the higher cardiac output you will achieve. So at a given right atrial pressure and a higher mean circulatory filling pressure, be it due to either volume or venoconstriction, will increase venous return and cardiac output. And what this shows here is this is like venous capacitance is lower. That's kind of like an opposite of sort of a double negative. It's like saying that you're no longer storing blood. You have kind of more redistribution of blood from your capacitance. And here's like higher capacitance, hence maybe more blood storage or hypovolemia. So, so the mean circulatory filling pressure minus the right atrial pressure times the resistance of venous return, which is kind of like an SVR analog. That is what gives you venous return and hence cardiac output. And what's kind of interesting is we kind of think of like, oh, let's crank a bunch of fluid in, let's make sure the CVP rises nice and high, and that'll give us a better cardiac output. Well, actually, that actually might create less spontaneous return of blood from the circulation at a given mean circulatory filling pressure. So, I mean, eventually it might equilibrate, but just because you have a high CVP does not necessarily mean that your venous return has been optimized. So at a single, so this is, again, doesn't appear too often clinically, but this just shows you what the resistance to venous return would look like in a couple different scenarios. One where three different ones. Let's say you're starting with the same mean circulatory filling pressure, and then in one situation, the resistance to venous return is decreased. So hence, there's probably less venoconstriction and there's more free return of blood. And then in this case, you have a higher resistance to venous return and not as high cardiac output. This might crop up in the situation where, say you put a very small ECMO cannula in somebody and you're doing everything you can to get blood out of the body so you can put it in the pump and so you can generate pressure and cardiac output with ECMO, but no matter what your pressure gradient is on, if you have, say, a small cannula that's creating a lot of resistance to venous return, you're probably going to be clamped at a lower cardiac output and your venous return is going to be lower, no matter what you do in terms of increasing right atrial pressure or mean circulatory filling pressures. So that does have some independent effect on venous return and cardiac output that we see clinically, although this doesn't really come up too often when we're dealing with cardiovascular physiology in the ICUs or in the ORs. Okay. So here you have 5.3 liters volume, and the crit's 27, and now you're still sampling the crit. With an ISTAT or something like that, it's still 27, but guess what? You've got a smaller volume because you're constricted with phenylephrine. So you can actually hide blood loss in this kind of scenario with the use of vasoconstrictors. If you're just dealing with kind of the same concentration of blood, but in a lower volume overall, you can hide the fact that you're losing red cell mass. So that's a caution. Beware of that. Okay, a few comments about CVP. This has come up in the arterial pressure regulation talk as well. So normally we're used to looking at double digits in our patients, but normal is like 0 to 4. And basically blood is more or less getting kind of siphoned through the right side circulatory system, and it can do so without very much right atrial pressure at all. And so, again, if you see a low CVP in the context of a situation where everything else is basically okay, you don't have to give volume. There's nothing to fix there. As we talked about in the other chapters, this is a back pressure which regulates organ blood flow, especially if the inflow pressure is a little bit tenuous. It's not a great measure of volume status. And it's in some situations, sometimes you just see it as a single point measurement. However, over time, if you see blood pressure tracking with CVPs, when the CVP is down, your blood pressure is down, and when they're up and are up, you can actually over time kind of create a little bit, this can become a dynamic measure of your filling pressures and actually give you some guidance as to what to do if you want to correct the low blood pressure. As that kind of gives rise to the thought that it's really, kind of the trends and correlations with other findings that add significance. So if you came up to me and said, hey, this guy's CVP is 10, what do I think? I think, well, is the guy sick or well, or, what's going on? You just can't make much anything out of it. I think the extremes, if you have a hypotension patient and your CVP is incredibly high or incredibly low, I think that can give you a pretty good hint where you want to look next and what you might want to do next. But most of the time you try to resuscitate a patient a little bit with fluids. You put a CVP line in, and then it's sort of like 8, 9, 10, 11. It's like neither here nor there. So you want to correlate this with echo findings if RV dysfunction is suspected. One number is never really a pure diagnosis of anything. You want to kind of correlate it with other things. And so those are some things that are good to know just about the numbers of CVP. The waveforms themselves are pretty informative. You have the AC and V waves. The A tracks with atrial contraction, and the C is ventricular contraction or ventricular systole. C stands for like the cusps. So the cusps are closing and sends a little bit of a wave back that's picked up by this pressure transducer. And then as blood passively starts to empty out from the atrium, and you start to see the pressure go down, and then you get sort of like this abrupt filling wave that happens when blood rushes in. It kind of creates a little bit of back pressure, giving rise to the V wave. And then when blood is actually when there's a lot more dominant blood flow going in from the atrium to the ventricle, that's when you see the Y descent, which is a pretty prominent downward descent. So the A corresponds with the P waves, the C corresponds with the R wave. What's kind of interesting is before the EKG was even invented, the phenomenon of Wenckebach was basically described by very careful observations of neck pulsations where they could pick up A and C waves, which have correspondence with the atrial and ventricular activity. So, and these kind of waves are the exact same waves that you'd pick up on a wedge tracing via PA catheter. So a CVP, these activities basically reflect what's going on the right side of the heart, but you can get the same thing that will tell you what's going on with the left side of the heart with a PA catheter in place and with a wedged catheter. So let's talk a little bit about the RV. It's a lot of times when you look at the echo, you can sometimes it looks like this co-equal ventricle, about the same size and shape and everything as the left ventricle. Not exactly in this picture, but when you dissect hearts, what you see is it's just like this really thin patch that's thrown onto a globular LV. And it's like not very muscular at all. It doesn't have a lot of work to do. There's a lot of flow that goes through there, same as that would go through the left heart. It has very low downstream resistance. Sometimes it just kind of doesn't have to contract that forcefully just to get blood moving from the ventricle into the pulmonary circulation, which typically is a very low resistance system as well. And so where we run into problems is we have patients that come in, they're septic, they're hypotensive, they're getting heart surgery where the heart stopped and receiving cardioplegia, and then we're asking the RV to kind of come around and really perform pretty well, perhaps with a higher pulmonary vascular resistance, or after not being preserved really well in cardiopulmonary bypass, or maybe in this setting of myocardial depressions from sepsis. And so this RV has had like little work history at all, and the 50 years has been around in your patient, and all of a sudden now it's really stressed out. It has to do a whole lot more, and that can be a setup for failure. So how do we evaluate it? Well, we look at it and see if it looks like it's keeping up with business. If you see a very blown out looking right ventricle that's not particularly hypertrophic, chances are it's over distended and it probably has not had to do that much work before in its life and probably is close to failing. There's various things that we can measure on echo. One is the tricuspid annular plane systolic excursion, or so-called TAPSE, and that's a measurement that's made at the tricuspid annulus where the leaflet of the free wall of the right ventricle is inserted, and you're comparing its movement in systole. Normally it moves about 25 millimeters. Less than 17 indicates right ventricular systolic dysfunction, and less than 14 is associated with poor prognosis in patients with chronic heart failure. So as we mentioned, the RV does not usually have to pump against a very high resistance. However, all of the blood that flows through your body does have to flow through your pulmonary circulation, and it's kind of a smaller region compared to the whole rest of your body, but still has to accommodate the same number of liters per minute of blood flow. So it does modulate. It's the pulmonary circulation. The tone is modulated kind of dynamically according to the saturation of venous blood flowing through it, as well as the oxygen tension that is sensed at the capillary-alveolar regions. And there's this phenomenon called hypoxic pulmonary vasoconstriction that's utilized to constrict in areas that aren't ventilated well, where there is kind of relative hypoxia, and that diverts blood away from these regions that would otherwise be shunts into areas that are better ventilated, where you can get better VQ matching. So it's kind of interesting. Sometimes you look at some people's chest x-rays and they look completely miserable, and somebody's on 30%, and that person's on 30% oxygen. And then sometimes you see somebody whose x-rays not terribly remarkable, maybe just a little bit hazy, and you learn that they're on 100% oxygen, and you wonder what the heck's going on. Well, chances are the one that looked really ugly probably has a highly functional hypoxic pulmonary vasoconstriction capability, where areas to the really crummy-looking regions of the lung, just blood is not flowing to those areas, and it's properly matched with ventilation in other areas, whereas the opposite's true on the x-ray. It looks basically okay. For some reason, the whole HPV system is probably poisoned by cytokines, other medicines, inflammatory debris, etc., that just prevent that constriction from happening. Our nitrovasodilators, as well as calcium channel blockers, interfere with this. And so sometimes when you see patients with pretty significant shunt physiology and you put them on a pretty moderate dose of some calcium channel blocker, you might see them become hypoxemic because those shunts are now becoming more manifest because you've interfered with HPV. Sometimes this can increase a little bit of afterload, so that can increase right ventricular strain, and sometimes it can actually even lead to high pressure overload and opening of PFOs in even healthy people traveling to high altitudes. So even though you have this system working for you, it's often important just to kind of practice good lung hygiene, make sure that you're suctioning patients, recruiting lungs, maintaining alveolar patency with PEEP, and that way this extra load on the right ventricle won't be as significant. In addition to nitrovasodilators and calcium channel blockers, anesthetic gases or inhaled agents also impair HPV. Interestingly, most things that dilate systemic vessels, things like high K loads, high acid loads, certain prostanoids, hypoxia, hypercarbia, all those things tend to constrict pulmonary vessels. They have the opposite effects. So you can get burned pretty badly sometimes, depending on what brew your body is experiencing. So how do we evaluate the RV? Talked a little bit about TEPSI. The other one is with a pulmonary artery catheter, we can evaluate what the pulmonary circulation is doing and hence get some sense of what the RV preload and afterload is looking like. A very convenient measure one can make is the pulmonary artery pulsatility index, which is the pulmonary artery pulse pressure, the PA systolic minus the diastolic, divided by the CVP. And when you get a number that's 1 or less, it is incredibly concerning for right ventricular dysfunction. And in patients with established pulmonary artery hypertension, a value less than 0.9 has associated with a high mortality. Some argue kind of persuasively that, well, the PAPI has really been only kind of validated and used in patients with pulmonary hypertension. Should I really worry about my patient without it? I kind of do, because I think it generally is associated with struggling RVs in my experience. And so my view is if I start to see the PAPI go downhill, and especially if it's, getting pretty close to 1, I'm going to do something about that. I'm going to try to see if I can improve the performance of my RV, decrease its afterload, decrease some of the strain and distension that's experiencing. Just try to be nice to it. So does this make sense? So like an RV that is failing is not going to pump blood very effectively. So the CVP is going to be higher in an RV that's failing. And so that's a higher denominator. So that's going to make this number smaller. So things will make this number smaller are a higher CVP, which makes sense if your ventricle is failing. And also if your ventricle is failing, it's not going to be able to generate a higher systolic pressure that's very much higher than the diastolic. So you might see something like 30/20 with a CVP of 15, and that would be terrible, because like 30 minus 20 is 10, 10/15 is like way less than 1. Whereas if somebody, has a PA systolic of 30 and their diastolic is 10 and their CVP is 6, that's pretty good. And so it's kind of a nice measurement that kind of integrates what the right ventricle is supposed to do, which is, generate pressure as well as move blood. And so in some ways it's kind of neat, because it kind of shows you a couple things that the RV is doing all at the same time. The answer would be that you would increase your cardiac, your pulmonary artery pressure. This would be high, and ideally, if you're lucky, this increase in pulmonary cardiac output might actually lead to a lower CVP. In that case, what you might see is the case of maybe an RV that's coming back and actually able to generate higher blood pressures or higher pulmonary pressures without necessarily failing and having a high CVP, suggesting there's a lot of blood pulled up that really isn't getting pumped. When you do see pulmonary hypertension, there are various classifications that are being used. Group 1 through 5 are those that have high PVR. Group 1 is basically idiopathic pulmonary hypertension, or used to be called primary pulmonary hypertension. Group 3 is the one that you get from COPD, cor pulmonale, and so forth. Those all have high PVRs. Group 4 and 5, which are kind of a little bit more like garbage basket groups, they're kind of a mixed bag of both high PVR as well as high left atrial pressures. But these are kind of your classic split is your pulmonary hypertension due to high left atrial pressures, something wrong with your left heart left atrial pressure, something's wrong with your left heart that's building up volume, or is it a PVR problem? So this is how you distinguish those using a PA catheter, and this is Swan-Ganz or PA catheter, and what you're measuring is as you float it forward, you're measuring the pressures that are experienced at the tip of this catheter. And so here you're going through a pulmonary artery. So everything that this artery is experiencing in terms of pressure is being transmitted here to the tip of the catheter. And then when this thing gets wedged in the pulmonary arteriole, the only thing that the tip is really measuring is what's downstream, because the balloon that you've inflated has kind of excluded all of this up here. And so what you can run into is a couple different scenarios. One is where you have your balloon inflated, you're kind of floating along through your pulmonary circulation, and then you wedge it, and your wedge is pretty darn close to what your pulmonary diastolic is. In contrast with the next scenario, where once this catheter is wedged and the balloon is only seeing what's downstream, it sees pretty normal pressures. This is like 10 versus 40. And so here's a patient with pulmonary hypertension, or two patients, let's say, identical twins. One's 65/38, the other one's the same thing. And this one has a very high wedge pressure driving the pulmonary pressure. And here, basically, the wedge pressure is not doing anything. It's all because of pulmonary vascular resistance. So this would be, say, your group 1 or your group 3P pulmonary hypertension patient, your core pulmonale or your primary pulmonary hypertensive that has high pulmonary vascular resistance. And this is kind of your left heart something pressure, either due to valvular dysfunction, heart dysfunction, whatever. So sometimes when you're taking care of patients with struggling RVs, and all of a sudden they're getting better, you see the pulmonary systolic crank up, and if you don't know the whole story on that patient, some people will look at that and go, "Oh my God, this is terrible, he's dying." But actually, if the PA systolic is going up and the cardiac output's going up and the CVP is going down, that means life is good. It means that the RV is coming back and things are actually better. So what happens when you do see RV failure? This is kind of the classic RV failure package. Well, first off, when you see the pulmonary artery pressure is high, figure out whether it's a high PVR problem, pulmonary vascular resistance problem, or a left-sided problem. If it's a high pulmonary vascular resistance problem, you're going to do something to lower that resistance. If it's a left-sided problem, you're going to be doing things that would increase left-sided output, be it diuretics, afterload reduction, inotropes being the primary ones, or fixing a valve, bypassing a heart, whatever, bypassing a coronary. So assuming that you have a high PVR problem, you want to reduce the RV afterload if appropriate. So if it's a left-sided problem and you start giving pulmonary vasodilators, you can actually create some hydrostatic pulmonary edema and things might be worse. But assuming that you have a high PVR and you want to reduce your RV afterload, inhaled nitric oxide, inhaled prostacyclin, here are a couple different brands that are out there. That's part of the package. You want to reduce your wall stress of your right ventricle, so diurese to the degree that you can. And then you want to add a inotrope to help support RV function until the RV comes back on its own. What agent you use really depends on how your blood pressure is doing. So if you've got plenty of blood pressure to work with, an inodilator like dobutamine or milrinone is totally appropriate. That will help left-sided output, that improve right-sided output. It'll lower pulmonary vascular resistance as well, and it'll give you kind of a nice result and to support RV function. Mistake that's made is if the blood pressure is marginal or low, some people say, "Oh, let's do an inodilator. Let's lower the PVR." The problem is if you think about RV perfusion, it's going to be terrible if you've got a low blood pressure to begin with. And if you use an inodilator, the blood pressure is going to be even worse. And so, yeah, you might make it easier for the heart to empty, but it's not going to empty because it's not getting any blood. And so you have to improve your systolic blood pressure in order for your RV to actually function. So think about, what your PA systolic pressure is. Let's say it's 80. Well, that's the pressure that's inside your right ventricle of 80. And if your systemic systolic is 90, you only have a RV perfusion pressure of 10, and that's not going to help you at all. So sometimes, you think, oh, this would be great. I'd love to see dobutamine in this patient. Well, for the time being, you might have to put the patient on epi or norepi just to increase the blood pressure to not only get the inotropy that you need, but actually get enough pressure so that your RV muscle will get some perfusion. So, you can do a combination of dobutamine and vaso if you can get away with it. There's kind of a ceiling on how much vasopressin you can use, so this is probably not like a can't lose combination. You probably have to start with epi, and if your pressure is really low, a little bit of vasopressins is also a rational choice. Unlike the alpha agonist, there are very insignificant numbers, if any, of vasopressin receptors in the pulmonary circulation. So while it improves systemic pressure and RV perfusion, it will not increase pulmonary afterload, which is a kind of a nice thing. So often when you see people whose RVs are failing, you're going to see them on epi, you're going to see them on a little bit of vaso, some kind of inhaled therapy to reduce PVR, and diuresis just to get the CVP and some of the wall stress down.